тема более специализированная. Мы что решили сделать, что немного продолжить.
So I changed the topic a little bit and talk about continue the talk that we started yesterday. Andrei Petrov talked about it, about the treatment of subdural hematoma. Unfortunately, he could not finish this presentation because we have a time limit. But I'd like to continue this discussion, and I would like to start this paper, which is very interesting. And if you deal with subdural hematoma and you like the idea of subdural hematoma embolization, you should definitely use read this paper. And you see the authors, and now they've been working on guidelines. Let's look at this figure. This is a transverse section, and you see that there are a lot of little capillaries, and we do not see lymphatic system here. And right now we are just coming to the idea and the concept of hematoma and chronic subdural hematoma and the reason why they occur. So we look if we look at the right bottom corner, look at the channels that are marked by H and A, and they show a net of capillaries marked by K letter. We embolize with the squid. All branches of meningeal arteries are embolized, and then we see this this spread of the embolizer. And it's when I saw it for the first time, I thought it was the extravasation of the contrast, but this is how we embolize the nidus, the locations, the cause of this hematoma, and that are filled with a liquid, a mixture of blood and lymph, creates this hematoma. This little arterioles and venules, arterioli and venuli. And if we look at the molecular mechanism of this tissues, and if we talk about subdural hematoma, we do not have any simulations in or models in dogs or rats or pigs. We are much better at we get much better results at modeling this modeling aneurysms, for example, in animals. But in case of subdural hematoma, we don't get similar results. And what do we need to perform this operation? We can use radial or femoral access. We choose the external carotid artery on the site that you want to embolize. We use 5 French slender, 5 French catheter. We can use Apollo or headway doer. And if we compare that to fistulae that have anatomical widening due to blood flow, of the meningeal arteries. As for subdural hematoma, the lesions are very, very small. On the side of the hematoma, we don't see any branches of the middle cerebral artery. This is the case when of a patient, female patient, who had hematoma that was developing very slowly, gradually, and we try to visualize to see the network of branches. We did not see anything on the right, and on the left side we saw a good network of collaterals and provided good anastomosis. So we embolized the right side. Andrei showed us yesterday of how we can move a microcatheter as far as possible. And we use as anatomical benchmark the side of the sphenoid bone, so that we don't follow any anastomosis, dangerous anastomosis. We don't damage any dangerous anastomosis, which can lead to very severe complications and problems. As for the MCO, we need to be very careful with it, not to damage any dangerous anastomosis. If you have time and if it's interesting for you, we can have a discussion about the most suitable adjunct for embolization. I usually use onyx, and I'm comfortable with this embolizer. There are also some geographical factors that we need to take into account. For example, availability of fill and squid, which are not really available in the USA. We could also use we can also use other embolizers. And I called my colleague today. He's been using coils for some time. And we had a lot of discussions and arguments about that. And I said that we cannot occlude the proximal branches of meningeal arteries. And if we do not occlude the distal part and the connection with the channels of neo and genesis, we won't get any results. But then I looked at the images, CT images, and it turned out to be really effective. Coiling is really effective, and there is a significant reduction of hematoma just due to closing of the proximal parts, proximal branches. Today we have more questions than answers. These are not fistulae or AVMs in which if you close one part, it will be fed by other vessels from the other side. The mechanism is completely different in case of hematoma. Andrei talked about this studies yesterday. They are conducted in the US. They're similar yet different. There was a study, Swift and Mr. Clean Prime for ischemic stroke, and the inclusion criteria were pretty wide, and a lot of patients could be included and enrolled into this study. As for Medtronic study, it is very precise. They have very definite and precise characteristics of and inclusion criteria, and a more complicated design. We do not have any randomized trials or prospective trials for patients with subdural hematomas treated by embolization. All we have is a retrospective analysis of all our cases, and we started trials which have two arms, major symptoms and minor symptoms, and whether this patients need surgery or observation, and this design requires more well thought structure. In one study that you see, they study small hematomas, while in BOLD study they want to study large hematomas. So we'll see the results. These two studies started simultaneously in around December 2020. They are right now enrolling new patients, and they do randomization. And in a year and a half, I hope that we will have good evidence on the quality of embolization and effects of embolization in treating subdural hematomas. As for Medtronic study, the trial is designed so that we can determine the difference if we need surgery or not in future. And BOLD trial includes radiological studies. Those patients who undergo CC can be followed for some time to see whether the hematoma decreases in size. The more we study this area, the more findings we get. When we treat hematomas, we improve the living condition of our patients. We decrease headaches. This is according to the study made by Barrow Institution. And in the right bottom angle corner, you see another study, middle meningeal artery embolization of a pediatric patients. This is a rare case. But our group of doctors operated a newborn who developed hematoma, and they successfully embolized it, and there was no need for surgery. And I'd like to stop here and summarize what we know and what we have. So, what are the issues that we face today? What is the most efficient way to treat subdural hematoma? I believe that total embolization with penetration to the branches and cause of angiogenesis is pretty effective in the short term. And patients with hemiparesis, paralysis, um, reduce the symptoms, and the size of hematoma decreased in the first 2 days. And in patients that I embolized, I was not really satisfied with the occlusion of distal parts, and there were a lot of open nidus in this patients. It is possible that these patients would need surgery later, and but these patients have lower risk of recurrence. Thank you very much.